Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Hi, and welcome back. This is Central Line, and I am Dr. Keya Locke, your host. Dr. Eugenia Ayrian is here with me today. Dr. Ayrian is the guest editor for February's ASA Monitor, From Awake Craniotomy to Thrombectomy, Evolving Practices in Neuroanesthesiology. We're going to learn about this fascinating topic from her today, so welcome to the show. Before we start learning about neuroanesthesia, let's talk a little bit about you. Can you tell me and your listeners a little bit about your pathway, your practice, and your passions?
Well, hello, Dr. Locke. Thank you so much for having me. It's truly a pleasure to be on the Central Line podcast. I really appreciate it. Well, couple things about me. I graduated from medical school in Yerevan, Armenia, and came to United States, passed my exams, and completed my anesthesiology residency at University of Southern California in Los Angeles. During my residency, I had the privilege of working closely with my mentor, Dr. Vladimir Zelman, professor and vice chair of the Department of Anesthesiology of USC at that time. His mentorship had a profound impact on my career. After completing residency, I continued working with him in the department, focusing on neuroanesthesiology, which ultimately became a lifelong passion of mine, alongside with medical education. Currently, I chair an ASA committee on neuroanesthesiology, and I'm especially excited about the opportunity to dedicate one of my upcoming monthly ASA Monitor issues to the theme of evolving practices in neuroanesthesiology. I want to especially thank all of my neuroanesthesiology committee colleagues for their tireless work on this assignment. Thank you very much.
So, can you talk to us a little bit about why you feel neuroanesthesia is an important topic? And can you tell us why this specialty is at the forefront of our field and why it should matter to those of us who are not practicing specifically in that specialty?
I believe neuroanesthesiology is an incredibly important subspecialty, and the variety and complexity of neurosurgical cases requires special attention and expertise. We always should remember that when we give anesthesia for neurosurgical procedures, while surgeons are operating, our role is to protect the brain, to preserve every brain cell possible, and whenever we can, convert all neurologic penumbra into healthy brain issue. This requires close attention to patient management, and this responsibility places neuroanesthesiology at the very forefront of our field. Many of principles that we apply, like physiological optimization of the patient, cerebral protection, hemodynamic control, they're all very important and relevant across all types of anesthesia practices. Therefore, sharing this knowledge helps with improvement of patient safety and better outcome in operating room in general.
I really liked how you put that, like no matter what we're doing, even if we're not doing a neurosurgery case, our focus should always be to protect the brain. I think that's a great take home. Thank you so much for that. Let's talk a little bit about the search for the perfect neurosurgical anesthetic and its history. Can you sort of give us a little reminder of where we've been?
Well, that's a great question. And we all know the quest for finding the perfect neurosurgical anesthetic has been going on for many, many years. We have been looking for a single drug or maybe single approach that would protect the brain during neurosurgical procedure. something that could prevent ischemia, maybe control intracranial pressure, or allow for rapid neurological recovery. And basic translational research has been going on for decades. But still, we cannot find that special so called magic bullet that will serve and save our neurosurgical patients. And perhaps it's going to be an important lesson that brain protection is not achieved through one agent or one technique, but it needs an individualized approach to every single patient, an application of physiology based care to them. And advances in neuromonitoring, in imaging, in anesthetic techniques, and multidisciplinary collaboration have significantly changed how we care for neurosurgical patients. I can proudly say that our neuroanesthesiology committee was tasked with very important work of highlighting the advances in the field and defining the most important questions in anesthesiology today. Those questions range from the treatment of strokes and management of awake craniotomies to monitoring of intracranial pressure, e.g., evoked potentials, and to management of pain in complex spine procedures.
Thank you so much for that. And I believe you've mentioned a few of the recent key advances across the neurosurgical field. Can you talk about the history a little bit more of awake craniotomy specifically and tell listeners how this technique is being used today?
Well, I really think that the way craniotomy history is quite fascinating. It goes from ancient times. And archaeologists in Peru have discovered skulls that were from more than 1,000 years ago, and they were with well-healed trepanations. And that demonstrated remarkable survival after cranial procedures that were performed centuries ago. Most likely, these procedures were done awake. Maybe it could have been possible that surgeons used rudimentary local anesthetic techniques such as cocoa leaves, because cocoa leaves are used coming from that particular era. And even in early 20th century, famous Harvey Cushing and Terry DeMartel brought away craniotomy back in modern medicine. And primarily, they were treating patients with epilepsy. Over past 2 decades, enthusiasm for awake craniotomy started growing exponentially. And the reason for it is the advances in functional neurosurgery. In modern practice, patient safety and patient comfort and real-time neurological assessment played very important role in management of awake craniotomies. My colleagues from the committee discussed contemporary anesthetic techniques, including scalp blocks and thoughtful medication selection, as well as different anesthetic strategies that allow patients to participate during surgery while remaining comfortable and safe. They also highlight the unique challenges of functional neurosurgery, where anesthetic management of patients during these procedures is extremely important for the surgeon's ability to place the brain stimulators in precise position. And I think this is very important to deliver to our readers.
In addition to those sort of specific technique, can you tell us a little bit about intraoperative neuromonitoring? We know that it provides real-time assessments of neural pathway integrity. So tell us what you feel we as anesthesiologists should know about this assessment.
Well, that is quite interesting because neuromonitoring becomes increasingly integrated in the complex neurosurgical procedures. And anesthesiologists who take care of those patients during the procedures are working with different modalities, such as EEG, somatosensory and motor evoked potentials, brainstem auditory evoked potentials, and so on. And those modalities are highly sensitive to anesthetic depths and also to hemodynamic changes, temperature changes, and even changes in patient positioning. This means that anesthetic management should not just be supportive of neuromonitoring, but should be specifically tuned to its accuracy and reliability. And it is important to say that communication among team members in the OR is extremely important. Communication between surgeons, anesthesiologists, neuromonitoring specialists, and so on, because changes in neuromonitoring signals should be assessed rapidly in order to prevent neurological injury. The team needs to distinguish between technical issues, anesthetic or physiological factors that affecting it, and true neurological damage. And this collaboration is really crucial for the timely differentiation between transient changes and permanent neurological harm. And I think that anesthesiologists must remain fluent not only in anesthetic pharmacology, but also in the troubleshooting and team based response to these critical monitoring modalities, and perhaps its official interpretation of their results. So that's what I think about neuromonitoring.
How interesting. I'm glad that you pointed out like it's the biggest challenge to determine, is something happening because of something that is happening on the surgical field, the anesthetic, and if it's even a true problem. And deciphering between those things seems like the most important task, correct?
Yes, absolutely. I really believe so. I'm working in operating room with neuromonitoring on daily basis. And that's exactly what is going on. We always communicate, we always talk, we always see what we do. Are we protecting the brain? Are we doing birth suppression? Are we like changing our anesthetic gas and techniques? So this is incredible, and collaboration is the best.
I'm switching gears a little bit. Acute ischemic stroke is a worldwide problem. Tell us about the evolution and current state of endovascular thrombectomy, or EVT.
Well, that is a very, very interesting topic because acute ischemic stroke remains a major global health problem, not only in United States, but worldwide. And thrombectomy has been one of the most transformative advances in stroke care. And it fundamentally actually changed the whole management of patients who are having large vessel occlusions. And as we all know, the anesthetic approach has been a very big area of conversation among neuroanesthesiologists. Early studies were associated with the promise that general anesthesia has worse neurological outcomes, particularly in patients with poor collateral circulation. And these findings raised very important concerns about hypotension, delays in REM perfusion because it took time to put patients to sleep, and also physiological instability of patient. However, most recent randomized controlled trials have significantly changed this thought. When general anesthesia is delivered with strict hemodynamic control and careful patient selection, outcomes become not only comparable, but sometimes, if patients are put to sleep, they have even more superior outcomes in comparison to patients under monitored anesthesia care. This data actually emphasizes the fact that it is not only anesthesia technique alone, but it is all together that the technique should be delivered very, very carefully. And that's what ultimately matters for the well-being of the patient.
Understood. And shifting a little bit from EVT to EVD, what should listeners know about managing patients with external ventricular drains?
Well, this is a thing that we do pretty much every day in the neuroanesthesiology when we are like operating on patients that are coming after traumas and issues like that. And it is very common that patients arrive to the operating room with external ventricular drain, EVD, that is already in place. And we know that intracranial hypertension in absence of EVD can lead to cerebral ischemia and ultimately to herniation of the brain, which is usually associated with very poor neurological outcome. So anesthesiologist ultimately becomes responsible for the management of EVD and during the transportation of the patient from the ICU to the operating room and also during the presence of patient in the operating room during the neurosurgical procedure. It requires constant vigilance of neuroanesthesiologists. We have to properly level it, zero the drain. We have to avoid over drainage or under drainage of the drain and monitor the ICP itself, especially during transportation of the patient and during induction of the patient in the operating room because even small changes in patient's position can significantly alter intracranial pressure. So attention to detail is a key to the success with those patients. So my neuroanesthesiology colleagues present a practical and clinically relevant overview of intracranial pressure per se. And also, they highlight core principles of drain management and discuss all the complications that may occur and need to be immediately recognized during the transport procedure itself. And those core principles are going to be discussed in the review, and they are guided by recommendation from the Society for Neuroscience in Anesthesiology and Critical Care. And they're crucial to neuroanesthesiology practice. So I believe this is a very important topic.
You make this topic, which may not be something that is the passion of everyone, sound very interesting. So I appreciate that. In addition to, us remaining vigilant and ensuring that we're well versed with all of these sort of neuromonitoring assessments and tools. On top of all of that, how should we be thinking about and approaching pain management with complex spine surgeries?
Well, this is a very important topic, especially that our population is aging, not only in the United States, but basically worldwide. And we are seeing a growing number of patients presenting for simple and complex spine procedures. And these patients often arrive to us with significant medical comorbidities and lifelong standing chronic pain. And it makes perioperative pain management extremely challenging. As we all know, we need to approach pain management very carefully and consider very individualized approach to every single patient. It is essential to recognize differences in baseline pain, in opioid tolerance, and also we have to remember about psychological factors that our patients have, such as anxiety or depression. And all of this influences postoperative outcomes. So pain management is extremely important. And effective anesthetic strategies should include multimodal analgesia, and it should target multiple pain pathways That's the way to cure pain if ever possible. And this approach can reduce opioid consumption as well and facilitate earlier mobilization of patients and actually make the functional recovery of patients much faster. Therefore, multimodal approaches represent a very important progress in improving of pain control and overall outcomes for patients undergoing complex spine surgery.
Thank you so much. And one last question before I let you go. I'm interested in your experience editing this issue of the Monitor. How do you feel about this challenge? And what do you hope our readers take away from this issue and this episode?
Well, editing this issue of ASA Monitor was both very challenging and very privileged. Okay. I found the process very rewarding, particularly because it reinforces the real importance of our specialty. What I hope that readers and listeners of the podcast will take away from these articles and the podcast itself is a sense of understanding that neuroanesthesiology is a very complex and consistently evolving field. And its progress comes from a deeper understanding of cerebral physiology, advances in the monitoring and application of individualized and evidence-based care. And while the journey is ongoing, we're steadily moving towards a future in which brain injury can be better prevented and hopefully ultimately defeated. I hope this message extends further beyond that episode and shapes the way we approach our patients and their care every single day. And again, I wanted to appreciate all our neuroanesthesiology committee team that put so much and so many endless hours to basically give it to the readers and be able to explain what is very important in the field of neuroanesthesia.
Thank you so much. I really appreciate you joining me today and sharing your experience and your expertise. Thanks to the listeners who joined us as well. You can learn more about this issue and topic at asamonitor.org. Please remember to like, follow, and share, and join us for more Central Line soon.
Hello, ASA. I'm Dr. Patrick Guillaume, your ASA president, and this is the Monday Morning Minute with recent highlights from the Monday Morning Outreach. First up, Elements and Penalties. ASA, the American College of Emergency Physicians, and the American College of Radiology convened a meeting with Elements to push back on its proposal to impose a penalty on facilities working with out-of-network clinicians. We urged Elements to abandon policies that pressure physicians into network participation and instead engage on patient-centered solutions. Next, ASA has published a couple of revised statements, one on anesthesiologist-led care and another on the physical status classification system. They're both on our website and in ASA's new Anesthesiology Open Journal. And lastly, through January 15th, we're accepting applications for 2027 committees and editorial boards. I encourage all members, including residents and medical students, to apply and get involved in ASA. Well, I think that's enough for now. So, thanks for listening, and I hope you'll follow us on your favorite social media channels and check out my weekly Monday morning outreach. Until next time, this is Dr. Patrick Guillaume.
For more detailed and timely information, don't miss Dr. Guillaume's Monday morning outreach email delivered exclusively to ASA members' inboxes every Monday at 5 a.m. Eastern. With a focus on content and information not widely or publicly available, BeaconBot fetches answers to your questions by searching through anesthesiology, committee resources, and statements and guidelines. Try it now at asahq.org/BeaconBot. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.